Okay, thank you. Evening, colleagues, and welcome to tonight's meeting. It's on NHI. Is it hype? Will it provide solutions? And Dr. Siva Pillay is going to address us on that, and I will introduce him shortly. I'm Dr. Jeff Govender, and I'll be the moderator. So I think you've read the message. We've kind of observed a moment of silence already while you were waiting. So I'm not going to read this, the content on the slide right now. I am going to now introduce Dr. Siva Pillay, who is a medical practitioner working in Uteneg. He's been in practice for over 35 years. He headed the ECIPA IPA and innovated capitation models. He was the previous Superintendent General of Health in the Eastern Cape. He was the previous Mayor of Uteneg, and currently he specializes in fetal ultrasound and does obstetrics and gynecology as a general practitioner. And he is going to address us on the topic of NHI. Without much further ado, I'm going to stop sharing the slide and hand over to Dr. Siva Pillay. Dr. Siva Pillay.
Thanks, Jeff.
Just to let you know, before you start, colleagues, this webinar is accredited for 2 ethics points. So we have your details as per your registration. We will submit that to HPCSA. Thank you, Siva. And then also thanks very much to Discovery Health for allowing us to use their Zoom platform, and Andres from Discovery is sitting in with us to assist from a technical point of view. Over to you, Siva.
Thank you, everybody. I won't be able to see everybody because I'm just going to look at my screen most of the time. The talk today is about NHI, and I think that there's a lot been said, a lot been done. And what is our worry now is that this bill is before Parliament and it has been passed in the legislature. Now it has to go to the NCOP.
One moment, just to the audience, that you all muted and you won't be able to unmute. If you have questions, you need to post it in the Q&A section, please, not in the chat. Okay, continue, Siva.
Yeah, thanks, Jeff. So it's difficult to speak when you just look at the screen. You can't see the people. But anyway, there's a lot been said, and this NHI bill, it's scary because it's already passed in the legislature now, and it's now before the NCOP. And if it goes before the NCOP and it's passed as it is, that's it. It's the law for the country, and it will go unless challenged. My view, and I think the view of ECIPA and a lot of people, is that while we support 100% NHI, we do not think that this bill is going to deliver NHI, and I'm going to try to explain that. The NHI is a noble principle. The principle that every citizen shall have access to equitable, quality health care at the time of need, irrespective of the financial circumstances. This is a fantastically noble goal, and we support this without reservation, 100%. But our contention and our submission is that this bill is not going to deliver that goal, and we're going to try to explain why. The first thing, by its own admission, Section 57 of this bill states that it will be implemented in 2 transitional phases over 6 years. So for the next 6 years, there's going to be no NHI. There's going to be no difference. It's going to be status quo as it is, and we're going to appropriate money, give it to a fund and a committee which is going to work in the background, hopefully, that they will be doing the groundwork to set the process towards implementation of NHI. Now you're going to wait 6 years for that to happen. And in these 6 years, if you look at the Act and what it says that it's going to do in these 6 years, the government was already mandated to do this for the past 25 years. Now, if in the past more than 25 years, you couldn't implement what you want to implement in the next 6 years, we as a public, if we pass this NHI bill, what guarantee do we have that it will result in the implementation of NHI? And we have none. there is a history of huge sums of funds that have been appropriated in the past from Treasury, all to implement policies that would take us towards NHI. And there's been huge amounts of money appropriated from Treasury in the past 25 years, with very poor or sometimes no results whatsoever. So the NHI has got a long history. It comes from 1942 onwards, from the days of Henry Gluckman. But I'm not going to go into the history. Anybody wants to go into the history of NHI, where it is, what happened, I've given a link on the top, and you can link onto that, and it will give you a full detailed history of the past. But in 1994, we put an end to all the debate, and we came out with a policy statement which said, all of South Africa's healthcare resources must be used optimally for all of its citizens. This is the bottom line, this is the foundation, this is what we said, and this is what has to be implemented. And it's a fantastic thing where we're saying all our resources will be used for all of our citizens in an optimal manner. And everything that has come from then has come. Now, since passing that statement in 1994 and presenting the ANC health plan, a host of policies, legislations, regulations, and other things have been passed. This year, the one slide that you see in front of you is just ending in 2005. If I had to go to 2013, it will take me 10 slides. But to say that there was really a will in 1994 to implement NHI, and it really felt the challenges of the previous government's Deregulation of Medical Schemes Act and the constraints of the financial burden that we were suffering with the debt that we had to repay. But notwithstanding all of that, in 1995, the National Health Insurance Committee came out with a plan where we would have had universal primary health care throughout South Africa, provided both in the public and in the private sector on a universal system. And it was called the Bill plan. But when anything is happening and change at that time, it was totally resisted. And the Bill plan was a fantastic plan, but it never saw the light of day. And many people, including a lot of service providers, just objected to this plan without even reading the plan. So from then, it was like, you couldn't move forward. And from 1995 to 1997, the whole process was stuck. Till in 1997, the Mafeking resolution said, listen, you can't go about this. Okay, if the people do not want a Bill plan, draw up a roadmap and then implement the changes within the health structure such that over a period of time, in a phased manner, and the phased manner should not exceed 10 years, that we implement NHI in 10 years. So if you look at it from 1997, if we took 10 years in 2007, we should have had NHI implemented. And they started with the process, and the first process was starting with the implementation of the Medical Schemes Act, which did many of the things that corrected the deregulation of medical schemes. Subsequent to that, in the year 2000, in compliance with this resolution, the Taylor Commission was started. Now, the Taylor Commission was a legislated committee of credible people that were asked to say, identify the problems. After you've identified the problems, put out what the problems are. Then come up with what are possible solutions. Canvass those solutions and come up with a roadmap. And in 2002, following and in the Stellenbosch conference, the roadmap was presented, it was reaffirmed, and the decision was go and pass this in Parliament now, such that we do not have any further delays, and that by 2008, NHI must be implemented. Now you must understand how law works. If the government and the legislature passes a policy, that mandate is given to the government to implement. And unless the legislature withdraws that, that is the valid mandate at that time, and the government has to implement that. When this was passed in Parliament, in both houses, the legislature and NCOP in 2002, In 2003, in the State of the Nation, President Thabo Mbeki said, in the next year, we will implement NHI. That's 2004. It's 19 years since, and we are still waiting for this NHI. Since then, there's been a plethora of policy changes and policies. And at some point in time, we have to say, guys, we have to stop this new policies, new acts, new legislation. Just implement what we agreed, because we are just changing the goalposts all the time, but we are not moving anywhere forward near the goal. So let's come back to what 2002 the Taylor Commission proposed. Now, I repeat here, this was passed in both houses of parliament, and it was given to Cabinet and the Department of Health as a mandate to implement. And this is what they were supposed to do from that time. The mandate involved developing an enabling environment, and I don't want to go through it, that is involved adjusting the budget processes, consolidation of the medical schemes. Then implement a preparatory reform. How do you reform things such that when you start to implement, you have a platform that in which this can be done? And that is you wanted the implementation of reforms in the Medical Schemes Act, in that you put risk equalization, risk-adjusted subsidy, you had prescribed minimum benefits, state-sponsored medical aid of GEMS, and a mandatory environment for civil servants, which is also GEMS. Then implement statutory mandates. I'm not going to go through those things. And then if you look at the bottom of the slide, you'll say that by 2008, we're supposed to have a central equity fund, and we're supposed to have NHI totally implemented in 2008. Now, what was supposed to happen was pre-1994, this is the situation. Budgets were appropriated, given to the public sector, into the 9 provinces. They went into public hospitals and primary health care. There was a medical scheme on the other side. It not risk-rated. It provided what we call curative care in private hospitals and primary health care settings, with some people utilizing the public hospitals, and there was a tax subsidy. Then the Medical Scheme Act was introduced. It said community rating, open enrollment, prescribed minimum benefits, and we included into that 2 major changes. One was that DSP, and we said the public hospitals is a DSP for all prescribed minimum benefits. So if anybody used the public hospital for prescribed minimum benefit, the hospital is supposed to be paid in full by the medical schemes. We also said that we will improve the hospitals, and the Office of Standards and Compliance will be set up, which will be ring-fenced. And then in the public hospitals will be accredited. The public hospitals will have differentiated amenities. And when we had GEMS as a state-sponsored medical scheme, they would have to use the public hospital as their DSP. If they use the private hospital, they would have to pay co-payment. And the anticipation was that the private hospitals will do buy down to compete with the public hospitals and to look at it. And if you look at it, then the medical schemes was saying we will put everything, both GEMS and the different schemes that are there, into one basket, and we'll put prescribed minimum benefit. And from the prescribed minimum benefit, you should have a risk equalization fund, so you don't have cherry picking, and you will provide healthcare based on need of the population and not on choosing young, healthy population and competing basing on choice of membership rather than on providing health care. And with this, the mandatory contribution fund was supposed to be put in, where large employers and state and public employers will be brought in, and social health insurance will be brought in. And that way, we were going to phase in through the Central Equity Fund, NHI, which will be running totally as we are running with our private hospitals, private care. Hopefully, the private care would buy down with the state hospitals, looking at patients and having differentiated amenities and having hard works to retain doctors and professors and professionals in that there, and we would have moved to health reform. Now, if you look at the timetable that was given in the Taylor Commission, this is the timetable. In 1998, the Medical Schemes Act was supposed to be put in. The Risk Equalization Fund was supposed to come in 2003. It is not there yet. The legislation for autonomic public hospital special dispensation to get differentiated amenities and to introduce differentiated amenities, it was done. We were the first in UTNEC to do that. But when we started to roll this out throughout the whole country, it just hit brick walls. We said we'll revise the tax incentives, and Trevor Manuel, when he was a Minister of Finance, started the process, but it never continued. We then said we'll have a government state-sponsored medical scheme, and that's when GENS came in. But then after that, the policy just stopped. And nothing further happened. And we've been going on like this ever since. And this is a problem. There were whole processes that was done at that time. So everything that is being proposed to be done in this NHI bill, in 2000 and 2006, it was already given as a mandate to say, develop a first pillar package, second pillar package, and a discretionary package. Look at how it will be funded. Look at how the NHI fund will work, how it will be distributed, how it will collect funds, what amount of funds will be needed, what will be the first pillar transfer. All of this work has been done and has been given to government, and it has been given to the department. And we did a costing model in 2007, hoping that we will get the budget allocation in 2008 to implement NHI. And I'm going to show you what happened. In the Medical Schemes Act, we put in a whole environment where we said from the Medical Schemes Act, pre-1999, it was unregulated. Then we said prescribed minimum benefits, open enrollment, community rating, extension of PMB, risk equalization. Eventually, we said each shall pay according to the income, and you get what is called cross-subsidization based on risk and salary. And that's supposed to go into a central equity fund, which would have been used. The idea was that in the medical scheme environment, you add billing systems, you add administrators, and the administrators are supposed to be accredited such that you move to normal administration system, patient registration system, coding, ICD-10, NAPI codes, and all of that, such that the environment using the medical scheme will be used as a base to move to NHI. And putting in social health insurance with compulsory cover for large employers and the government would substantially increase the medical aid base, and that would give us the knowledge for us to implement in the public sector, taking into consideration that we made the public hospitals a guaranteed DSP with guaranteed payment. To give you an example of this, UTNEC Hospital just did one ward, and it generated enough income to renovate the whole hospital. And that's why you can come to UTNEC today. Our hospital stands up above most provincial hospitals because we generated the funds, but the process got killed thereafter. So this plan, despite being there, despite being documented, despite being mandated, it just took too long to implement. And then there was paralysis in analysis, inertia of initiation of the new reform that's supposed to be taken. And in the implementation of the policy, it was patchy, uncoordinated implementation. And when you had change in leadership, both at national and provincial level, one did not know what the other was doing, and there was and there was no institutional memory. Coupled with this, you had stakeholder ransom and poor stewardship. The whole thing never saw the light of day. So despite all the various committees of inquiry, by 2008, the government still lacked a documented vision of a coherent, sequenced reform roadmap with timeframes for implementation of NHI. They had a policy, but it didn't have an implementation plan. And that is the problem. And when different leadership came in, they kept changing things without a coherent plan. Now, NHI is a long-term process. It's a phased process. It's a long-term process and a long-term goal that needs consistent leadership and champions with institutional memories for successful implementation. You cannot change MECs, HODs like you change underwear and then expect that there will be an implementation process, especially now when you're not implementation from one central Department of Health, but the constitutional mandate, it says you have to work through 9 provinces. And during those times in those 9 provinces, when you looked at the 9 MECs, you have only 2 who have got health qualifications. So you have a problem. So what were the wasted opportunities of the past? The first wasted opportunity, and that's what made Thabo Mbeki announce that in 2008 we'll implement NHI. We had a budget deficit because we were paying foreign debt that we incurred, which the previous government of apartheid incurred, and our debt repayment from our GDP was 19.1%. We had a windfall in 2007, 2008, where the debt repayment by negotiation by others, Madiba and all, came down to 9.5%. So we had more than 10% in our GDP as an additional allocation and a windfall. But instead of using any of this money for health, what did we use the money for? We used the money to give grants, social welfare grants. We gave the money to social security. And then the nonsense that took place, the budget of defense, because all of you knew about the defense procurement that took place at that time, and the budget increased. And all the stuff that they procured with that defense budget actually gone to waste, because half of it then we never used. It was just a waste of money. And then if you look at what happened to the healthcare budget, it didn't proceed. And that's when GIA came in, and GIA said, no, we won't allocate money to social development and social reform. We'll allocate money to economic growth. And the economic growth will bring about enough economic growth for us to get a trickle-down effect, and we'll have enough budget then in health, education, and the others. The trickle-down came to not even few drops, and it trickled to a drought, and nothing trickled down. And as you can see from this year, if you look at this, where we had a progressive increase in allocation of budget, in 2007, it dropped again. And that's it. NHI died there. And that's the reason. Now, we spent a huge amount of money. A bill was passed, which is called the Medical Schemes Act. It went to Treasury. It appropriated money. And it said we want to set up a Medical Schemes Council, and the Medical Schemes Council will regulate medical aids. It will be the vehicle which we will use to drive NHI and to bring NHI in. If you look at the CMS now, the Council of Medical Scheme is totally rudderless, without direction. And after the white paper, you'll hear flippant remarks made by legislatures and the government. Don't worry, we're going to close all these medical schemes down, so we're not worried about NHI. So hence, PMBs, which are supposed to be reviewed, has not been reviewed. And if some medical scheme takes the Council of Medical Schemes to court and the government to court to see how PMBs have not been reviewed as per the Act, the PMBs can go out tomorrow. The risk equalization fund is not being pursued. The whole idea is abandoned. Now, if you talk about the central equity fund with GEMS and PARMED, it's just totally abandoned. No one is even talking about it. The most important thing, when you see people coming and talking about this NHI bill, they come and say, you know, this medical aids of yours is useless. That's why we must close it down. In 3 months' time, your medical aids is finished and you come back to us as in government. That means this very people that are saying this, they do not know their own act that they passed. Because Section 29P of the Medical Schemes Act is very clear. It says, 1, if you provide any prescribed minimum benefit in a state hospital, the medical scheme must pay for in full without co-payment or levy. So now that's anti-dumping legislature. But if the state hospitals did not bill, they did not get money. When I became the HOD of health, I went to the principal officer of GEMS, and I said to him, you know what, Eugene, our department is messed up here. You know, you guys are using our hospitals. He said, Shiva, I know you're using hospitals. We want to use your hospitals, but you don't bill us. And then I went back and I said, help me, give me your ID numbers of your membership. I'm going to run it through the people that used our services and see what we can bill. And we billed in 1 year 48 million rands. And that money is what could have been appropriated from the medical schemes that came to the public hospitals. But since then, the UPFS tariff has not been managed. People are not billing. There is no capacity within the provincial hospitals to bill, and then the whole thing is not understood. That's why you can get a deputy minister who now can stop and say, you know, when he was doing consultations, you know, when the cancer patients get cancer, they are dumped to our state hospital and we have to carry the bill. We say, why? You got Section 29P, bill for it. But he doesn't know what we're talking about. And that's scary when your deputy minister does not know his own acts. And therefore, the groundwork for pursuing of NHI was not pursued. There is no administration system. There is no basket of benefit development. There is no cost analysis for a basic basket of benefit in primary healthcare. And universality of membership with digital records and portability of membership, which would have come through the Central Equity Fund and the risk equalization mechanism, is not even pursued at this present moment. So the whole thing is a wasted opportunity, because the money that you appropriated for the Medical Schemes Act, which was supposed to bring about NHI for us, is just wasted. The second wasted opportunity is that we said, okay, the provinces, when they get budgets, they don't do what we ask them to do. So let's make it in conditional grants. We'll say, we'll give you money in a grant form and you must implement this. And this policy was never fully understood nor implemented. A hospital revitalization grant was given to build differentiated amenities, where provincial hospitals were supposed to just go build 1 or 2 wards in the hospitals to cater for the GEMS and the PARMED patients and any other patients like Transmed that wanted to use the facility as a DSP. They were supposed to do this, but instead of this, they took this money and built new hospitals, built new clinics, not having any idea that this money was for income generation and for differentiated amenities. So that whole appropriation was lost. Then we said, no, we're not having the ability to get doctors, specialists, and nurses into the public servants. So we gave a health professionals and training development grant. A joke of this is that huge amounts of money was given as grants for people, and they were trained even to a specialist, and we paid these specialists. And when the time came to them to be employed, you got the provincial department saying we have got a moratorium on employment. Even now, the Eastern Cape government says we have a moratorium on employment. When if I say there's a shortage of specialists here and there, and here's a specialist who wants to join, there is nothing. It's dololo. And these are people that we paid for, by the way. There is no development of the district hospital system with a basket of benefits that each district hospital is supposed to be provided with, to provide to the community. The UPFS system, which is a universal patient fee structure, was never implemented. None of the district hospitals or the hospitals have any capacity for billing, revenue retention, revenue generation, and managing this process. The whole process of RWAPs is totally misunderstood. RWAPs were supposed to be for people working in the public sector, to work in the public hospitals, to see private patients. And it would have been a symbiotic relationship where if we saw private medical aid patients, the doctor would have got extra money above his salary, plus the hospital would have been able to bill for the services that it's rendered to that medical aid patient. And you have got Section 29P of the Medical Schemes Act that is guaranteeing you payment. And that's how the public sector hospitals are supposed to compete with the private hospitals. And this whole opportunity is lost because you cannot make a DSP arrangement now in the public hospitals for GEMS or PARMED, because they're going to say, where is this facility that we have to go? Then the whole thing said, no, the private patients, we can't send them to these facilities. At least let us look at the tertiary services. So we gave a national tertiary service grant to say, look, all provinces, take this money, go and plan, modernize and transform your tertiary services. So at least if you provide the tertiary services, you'll be guaranteed payment by the medical aids, and you can use that money to cross-subsidize your state patients. Nothing happened. You then got an appropriation of money that was to say, let's build an Office of Health Compliance and Standards. Incidentally, every hospital and facility in the Eastern Cape failed the standards of the OHS, or Office of Health Compliance and Standards. Now, a question that I have to ask the unions is this. If you got this NHI bill passed as it is, and it says that it is going to buy services, and public hospitals have to be accredited, and if you fail accreditation, what is going to happen to your hospital? What is going to happen to those workers? Are they going to become made redundant? And with the history where the department is not improving the hospitals, and you have got a history which shows that the Office of Standards and Compliance says not a single facility in the Eastern Cape qualifies, we're in for disaster. And we're in for retrenchments. So Neil Sunderland in that way did a fantastic study, which was the basis for hospital revitalization and differentiated amenities. It said what a hospital package must be in a provincial hospital, what will be the cost, how much must they charge, what will be the UPFS tariff. We did affordability studies. We looked at what will be the cost for the hospitals. We looked at if they charge this amount of money, how much will they generate. Just to give you an example, we did this with one ward in Utenay, and we were able to generate enough funds to buy equipment and to upgrade the whole hospital in 2 years. Now imagine if we implemented this all over, where would we be now? At the present moment, even what we started in Utenay was killed because revenue retention and other policies didn't get passed, and Treasury started appropriating money without giving back money to the facilities. So nothing has been implemented. So another wasted opportunity. As I said, we had a health professionals and training development grant. They were supposed to be ring fenced for professional development. They were supposed to use to revitalize the hospitals such that there could be DSP arrangements for GEMS empowerment. These professionals are supposed to be given rural allowance as well as ROP so that they can earn extra money and be retained. By the way, the rural allowance is 22% more than what your salary is. The departments did not even employ those that they funded, despite the hospitals collapsing. And as I said, now ROPs are given for people to go work in a private hospital. So the policy is totally misapplied and is actually contributing to further collapse of the public hospitals. The Office of Health Standards and Compliance was set up, and it was supposed to be an accreditation facility in preparation for NHI. The initial reports were damning, and all facilities in the Eastern Cape failed. Western Cape, about 70% of the facilities passed. But instead of using this as a basis to improve the health facilities and say, listen, guys, if you're going to prepare for NHI, we need to improve these facilities. Now, because this damning report came, the Office of Health Standards and Compliance is just being made to collapse, like the Medical Schemes Act, so that it loses its bite. This is amounts of money that was appropriated for this, and you've got these people earning salaries now, sitting in an office, but doing nothing. Now, if you look at this NHI bill, it is proposing to do exactly what the Office of Standards and Compliance was supposed to do, and they're saying we will make another committee that is going to be looking at accreditation of providers that we're going to contract with. Then why did you send up the Office of Health Standards and Compliance? It doesn't make sense. And why is this bill proposing something to be duplicated that is already there? Another wasted opportunity was GEMS and PARMED. It was hoped that if government officials and if elected officials used the public state facilities as a DSP, this would serve many purposes in the alignment of the policy towards NHI. Since the members will be government employees, they will ensure that there is a better service. Because they will be utilizing the services. You should have a revenue generation. You should have fund shifts to the public sector. You'll have the ability to compete with private hospitals. You'll have the ability to develop capacity for billing, revenue generation, revenue retention, and a sense of competitiveness. Now the hospitals want to do less and want to be paid more instead of being competitive and working harder to generate more income. The UPFS tariff has never been revised. ROPS is being totally misunderstood, and the people, instead of these things improving the public hospital, they're actually now disadvantaging the public hospitals. To give you an example, now the UPFS tariff has not been upgraded in Eastern Cape since I left the department in 2012. Now, the policies are neither understood nor implemented, and we actually go and appropriate money to do these things. After all of this, then we put out a white paper, and then we first put out a green paper, then we put out a white paper, and we said, okay, no, this thing took too long. Let's try it in a reverse manner. We will go down to the ground and implement pilots. And they got a huge amount of money that was allocated from Treasury to start off 10 pilots. In fact, it was not 10 pilots, it was 11 pilots. None came anywhere meeting any of the objectives that the report, and there is no report of what they did, and there is no report of even what are the lessons that were learned. There was no stewardship to this process. It was rudderless, and it was another waste of appropriated funds. Now, if these departments, the national and the 9 provincial departments, I will say 8 because Western Cape succeeded. If the department and the 8 other provincial departments fail to run a single NHI pilot site successfully, how can they be trusted to implement NHI nationally, wherein they are proposing a single purchaser agreement, thus collapsing a vibrant medical aid industry, which is actually working, for something that they don't know how to implement or have implemented. And you couldn't do it in a pilot. How are you going to do it for the whole country? The integration challenges where the Health Professionals Act was supposed to be integrated, they come and say to you for primary health care, you should have a multidisciplinary group of people working together. You cannot do it because you've got the Nursing Council, Pharmacy Council, Health Professionals Council, Dental Council, Allied Professionals Council who cannot work together. The laws in the country don't allow you to work together. If I am a GP and I want to work with a specialist, I'm not allowed to do that. And the Health Professionals Act was supposed to be revised in 2008. We are still waiting. It has been drawn up and not done. The Competitions Act was supposed to have exemption, not done. Managed administrators and managed care organizations under the Medical Schemes Act was supposed to give us the instruments for the implementation of NHI, nothing. The worst was the National Health Act and the Provincial Health Acts got passed. And they all said we will decentralize services. The National Health Act in its promulgation didn't say by the promulgation of this act, we will set up district health authorities or we shall set up district health authorities. The National Health Act says by the promulgation of this act, district health authorities is hereby established. So it wanted to compel the departments to establish district health authorities where there will be people's participation in the process and accountability at a district level. I want to ask, where is this single district health authority in the whole country? Despite the act being passed in the National Health Act and the Provincial Health Act. The key issues of the inefficiencies within the public sector has not been addressed. The market structure is neither competitive nor inclusive. The service delivery platform is crazy. If you look at the Eastern Cape, you have 69 district hospitals, but they are glorified clinics. The district hospital cannot even do a Caesar. They cannot even do a DMC if a patient has a miscarriage. But there are district hospitals where you're paying CEOs, where you're paying provincial, what is called clinical managers and other things like that. So the service delivery platform of a course functional provincial hospitals with spokes and a referral system, not there. We're supposed to have decentralization with autonomy of managers in a district health system, not there. We're supposed to have proper distribution of service, not there. We're supposed to have better healthcare delivery with primary healthcare prioritization, meeting the standards of Office of the Health Standards Compliance. Now, this act is passed. We're supposed to be complying with the Office of Health Standards Compliance, and we don't comply. Those facilities are supposed to be closed. And if you've applied the act, every facility in the Eastern Cape is supposed to close. We said that we must better manage supply chain management and HR management, and we must contain corruption. Now, if you have not did all of these things, which you are supposed to do, which you are mandated to do, which was given to you as a legislative mandate, you come and now and say, we want to appropriate money again because we want to bring an NHI bill. But this is real nonsense, because this is not an NHI bill. This is a bill to appropriate money to set up an NHI fund. The only thing that this bill is clear about is going to set up this fund, which is going to appropriate money. And it is going to be a single purchaser with a single payer system that will be purchasing healthcare for the whole country. That's the only thing it's going to do. And in the next 9 years, after we set up this fund, we will look at how to do the things that we need to implement. And all the things that you said you're going to do in the phase 1 and phase 2, you have already paid and given mandates to people to do, and you gave money to the medical schemes council to do, and nothing has come from that. Now you want to give more money to this. So I said to the portfolio committee, before we agree on this bill and another appropriation, we should request a clear, documented, coherent, and sequenced reform roadmap with timeframes for the implementation of NHI. Don't talk to us about setting up a fund, because setting up a fund is not equivalent to setting up NHI. Who's going to do the other work that we asked you to do? The bill as it stands is vague about a roadmap. It's only clear about the establishment of NHI fund, and it proposes a single purchaser, single payer system, which is untested, highly risky proposition without the building of a proper foundation. If this bill is passed tomorrow and we say that we have to accredit, this fund is established and we have to accredit hospitals to purchase from this, then every healthcare department in the Eastern Cape will have to close. And I don't know where this NHI fund is going to buy services from, except the private sector. So by setting up a fund without doing the work about delivery of service, where 80% of the people depend on the state service, we are putting the cart before the horse. Now we are making false promises and playing on the hopes of universal coverage. When I go to the public meeting, the people are saying, do you accept this bill? Do you vote for it? The people want NHI. So they say, yes, we vote for this bill because they want NHI. But they don't know that this bill will never deliver NHI. It's going to deliver you an NHI fund, but it will never deliver you NHI. And it's not told clearly to people that in the next 6 years, you're not going to see NHI. You're not going to see anything near NHI. You're just going to see a fund which is going to set up committees, which is going to do works. So our submission is that we are putting many policies and promulgating many legislations. However, although the Taylor Commission and other policies propose a realistic roadmap, there is no coherent implementation and sequencing. The implementation is patchy, inconsistent, and incoherent. Some policies are not understood and wrongly implemented. If you say that now the National Health Act said we'll have a district health authority and decentralization with budgets, nothing. If you said the Medical Scheme Act is going to pursue risk equalization fund, nothing. If you said it's going to be a PMB review tomorrow, somebody medical scheme wakes up and says, I'm challenging this PMBs because it's not been reviewed, we're in trouble. If our own deputy minister can come up and say, no, your medical schemes only last 3 months because when your medical scheme is finished, you come to our state hospital without understanding that we put anti-dumping regulation for him to start billing those people and not billing them, then you blame the medical schemes. If you didn't do your hospital revitalization and you didn't put your UPFS systems in place, how is that the problem about the private sector? The public sector didn't do its work. GEMS and PARMED was set with a huge appropriation of money. You know, in GEMS, if you take the Tanzanite and the OINCs and the lower options, they are subsidized 100% by the government. But yet they can't use the public hospitals because they don't generate money. RWAPs, as I said to you, is misunderstood. And if 11 pilots have wasted funds and achieved nothing, there is no guarantee that the 6 years that is being proposed in the transitional period of this bill will not be the same. Especially when this bill is saying, give us this money for which we already gave money and for which we already gave a mandate in the last 25 years, in which they did not do, and now which you want to duplicate with this bill. So our submission is that, you know, this NHI bill, while you want to implement NHI, this bill that NHI is talking about, a bill that they are talking about, it will mean nothing. It will be passed in Parliament. But unless the Department of Health first implements the mandate and does the groundwork to improve the delivery platform, NHI is not going to happen. We'll set up a fund, but NHI will not happen. NHI cannot be developed, implemented in a vacuum. The current structure has to be reformed, and it cannot be done by legislation. It has to be done by implementation of the fundamentals of the agreed upon roadmap that we talked about how to do this. We want to say the objective of the NHI that to ensure that all citizens have appropriate care at the time of need, irrespective of the financial circumstances. We support that. But this bill is not going to bring that. And we wanted to say that NHI already exists for 85% of the population who use the state service. And if the state service did its work competently, we would have NHI already. We don't need another bill and another appropriation. And we don't need another structure to do what we have already started to do and for which we gave you money to do. Now, if you look at the bill, and if anybody read the bill, and I have the bill in front of me, if you look at the purpose of the bill, everything that it is wanting to do in the purpose, which is the preamble, it's covered in the National Health Act. If you say you want to set up a fund, and if you look at government budgeting processes, government in its budgeting process can set up funds. Government in its budgeting process within the department can have what is called earmarked funds. It can have conditional grants. So why do you want to set up another fund? And I will tell you something about this fund, which is very, very scary just now. Then you say you want to define beneficiaries. The National Health Act already defined beneficiaries. You say you want to accredit providers. This is a disaster because already you didn't amalgamate the Health Professionals Act to make us all under one professional act and unify the Nursing Council, the Pharmacy Council, Health HPCSA, and Dental Council. It's already flawed what it is there. And now you say now you want to set up another accreditation process for accrediting providers. And we want an appropriation of funds and give funds to this fund to do that. Then what are these people going to do? The Health Professionals Council, the Nursing Council, the Pharmacy Council. So you're going to duplicate. Then you say you should register users. This is the thing that makes me absolutely go bonkers. We never learn lessons. If you register users, everybody has got an ID document. That is your user passport. Now, we had a debacle with the driving license where we said, instead of using your ID document for your driving license, you go and set up a new registration process for driving license. And then in France or Germany, this machine breaks down and then we can't issue driving licenses. The same thing happened with the SASA card. We give gold card, yellow card, SASA card, Home Affairs card. Why the hell do we need to register people 5, 6, 7 times? You go to Home Affairs, that's registering people, register them this thing. Now you're saying now you want to give another registration process for health, which is going to be debacle like the SASA card and the license. This is nonsense. The rights of users are covered in the National Health Act, and health services coverage is covered in the National Health Act and the Constitution. If you look what is going to be done in the 6 years of the transitional phase, is going to be duplication of function and a further appropriation of funds to be wasted, like the 11 pilot projects and the other appropriations. Government must implement the mandates of reform already agreed upon and for which they already appropriated money before any further bill and appropriation of funds can take place, especially if the bill as it stands is not going to tell you we're going to implement NHI after 2 or 3 or 4 years. It's going to say after 6 years, and we'll look at it happening. So a major concern that we have, which is specific concerns, you're going to set up a NHI fund and it's going to be housed as a Schedule 3 fund of the PFMA. I don't think people know what is Schedule 1 fund, Schedule 2 funds, or Schedule 3 funds because, we're a little bit ignorant, we're ordinary people. But a Schedule 1 fund is like constitutional mandates. It's like the IEC, it's like the Public Protector's Office. So that is appropriation of funds. Schedule 2 funds are all the SOEs. Schedule 3A funds are joker organizations that are going to be controlled. Let me give you examples of Schedule 3 funds. Schedule 3 funds are Artscape, Boxing South Africa, Brand SA, Castle Control Board, Ingonyama Trust. Are we serious? You are saying this fund is going to buy healthcare for the whole of South Africa. And it's going to be a Schedule 3A fund like the Ingonyama Trust and Boxing South Africa. And that's the oversight it is going to have. It is worse, it's not even another SOE. If it is another SOE, the SOEs are listed under Schedule 2A, and their track record with their oversight is already known. Now, if you put this under a Schedule 3A fund, which has got less oversight, what the hell is going to happen to this fund? There'll be a feeding frenzy there which we don't know about. The ANC policy says the people shall govern. Yeah, the bill is proposing that the minister, sitting in a small room of his own, will decide who the board members are, and they will have control over the whole funds that is going to control the funds that will buy healthcare for the whole country. Not parliament, not the people, but the minister. Now, when you say the people shall govern, why are we saying the minister and his board of cronies that he will appoint to this fund will govern? Now, if you are serious about this, you should make this a constitutional fund under Section 1A, and you should have Parliament choosing who the board members are. You should have an open public participation process. You should have transparent interviewing, not some person sitting in a room decides who he wants. They will make this fund, they will control it, they have total authority, and they are not accountable to, they are accountable to the minister. And then they've got a Section 3A accountability, which is absolute no accountability whatsoever. Then you're saying this fund is going to be a single funder, single purchaser system, no phasing in, totally untested, putting all the eggs in one basket into a single fund. Very, very, very risky. Now, you're saying that you're going to set up this single fund, and then at the same time, you have a constitutional mandate which said that the 9 provinces have the mandate to provide healthcare. So how is this going to be working? Because you'll have to change the constitution first, or you'll have to change the function of the provincial departments. Because this fund cannot appropriate money and buy services for the whole country, and then you say in the constitution it is a provincial function with the provincial mandate. And as I said, Section 57 already says it's going to take another 6 years. And if you look at what they're going to do in those 6 years, go and read the bill. It's going to do exactly what we already asked them to do. So if I am being cynical, and if I'm being really, really cynical, I will ask, is this window dressing before an election? And are they playing on our emotion, in our desperate desire for an NHI? Because we say we want to do NHI, so you put any nonsense that you want under an NHI bill, and you can set up this fund. If I want to be also cynical, I can say that that fund was set up totally for appropriation of money for individual benefits. And if somebody wants to sue me for that, I will ask them, why then would you want to set up a fund that has equal oversight to Boxing South Africa when it's going to provide healthcare for the whole country? Unless you want to appropriate money for that for personal use. So therefore, I'm saying that this fund, if it is set up as it is supposed to be set up, is going to be disastrous because it will appropriate funds and we will have no control over that, and it's going to be a problem. So this bill is definitely and deliberately vague, lacks a documented vision of a coherent sequence reform roadmap with timeframes for implementation. It's just promising NHI, but what it's actually doing under this bill of calling it an NHI bill, it should be actually called an NHI fund bill. But instead of calling it an NHI fund bill, you call it an NHI bill. So all of us, including my comrades from the ECIPA and COSATU who want NHI, say yes, we support it because they think they're supporting NHI. Meanwhile, they're supporting establishment of a fund. They're not supporting NHI. And if you look at it, the objectives of NHI is 100% supported by us. And is to ensure that all citizens receive appropriate care that they need at the time of need, irrespective of the financial circumstances. We are saying it exists, guys. It exists for 85% of the population. Just get the state service to do its work competently. Now, if anybody wants to go and review this thing further, I give them this one slide because Alex van der Heever did an enormous amount of work, and you can go and review some of the things that he said in addition to what I'm saying. And I'm saying that if this bill is challenged, it is going to fail in the constitutional court because it's in conflict with the constitutional mandate where provinces are given the function to provide healthcare. It's in conflict with Section 27 of the Constitution, which is your Bill of Rights, because you have a right to access healthcare. Medical Schemes Act exists at the present moment, and members exist on the medical schemes at the present moment. So they have access to that care. It's a right that has been given to them. If you withdraw that right, then you are in conflict with Section 36 of the Constitution, where if you are going to limit certain rights, you have to say why you are limiting those rights. What is the basis for limiting those rights? If you are limiting those rights, what you are putting in place, can you guarantee that it will ensure those people the same rights that they had before? Is there no other alternative than to withdraw those rights? And is this for the better good? And I don't think that this bill must have constitutional master on Section 36 for a person who will say, I want to stay on a medical aid. And that's there. Now, going further, the Constitutional Court has ruled 3 times, and we have, even right now in the Zimbabwe case now, where the Home Affairs said we want to deport all Zimbabweans, and they said you want to pass a bill. The court ruled that the consultation process must not be window dressing. It must be substantial, it must be informed, and it must not be flawed. So in this, you should have a credible consultation process where credible information is given out, not misinformation, where a deputy minister can come and say, you know, your medical aid finishes in 3 months and then we have to carry the burden, when he does not understand Section 29P of the Medical Schemes Act. You get, Olive Shizana will say, you know, 49% of the medical aid population are white. What she meant that is 49% of the white population are on medical aid, but the majority of the medical aid population are black. So if you give false information like that out, when you're passing this bill, and then you have a consultation process, you have a problem, because the consultation process has to state that you have to state what the problem is, and you have to do a diagnostic report. Then you have to canvass options for intervention before you just propose things. Then you have to consider solutions taking into consideration the existing environment, and then implement. This narrow top-down political process where you frame a policy endpoint, and then you pressurize role players and stakeholders to legitimize it and offer technical content to make it feasible, is crazy. It's not a consultation process. And that's why when I went to the portfolio committee and I said, do you all know about what you are proposing here? And they didn't know anything about what I was talking about. Now we are told, no, come and address the portfolio committee again. So that is our position. Now, if you look at this, the Davis Tax Commission itself said this whole proposal is flawed. I don't want to read what it says there. It just says that what you're proposing here is a pie in the sky. It's a thumbs up. You have not framed the policy, you have not framed the question, you have not framed the solution, you have not even framed how you're going to provide the solution. And you didn't even frame what it would possibly cost. But you're saying you want to implement an NHI and you want to set up a fund. And that to a single purchaser and single provider. So this is government's own tax commission of what is it. So for me, first, this is not thought through properly. Second, there's lack of evidence that there is a public purpose for this bill at this present moment. This bill is promising us an NHI fund. It's not promising us NHI. And if there is no evidence to show that the NHI fund, if it is set up, will bring about NHI. This is like, I'll give an example of this. ESCOM is given the task of providing electricity for the whole country. Now, instead of saying we will all go and buy electricity from ESCOM will provide it, then the mines and the big employers got a structure like a medical schemes to provide electricity for them, then say, no, we're going to take everything and we're going to set up a fund. This fund will pay for electricity and it will give you the electricity that you need appropriate to your need. Where the hell is the electricity going to come from? So there's no evidence that this is going to serve a public purpose. That it is not based on a coherent rationale, because we have shown that it is flawed all along. Fourth, there has not been evaluated on any feasibility, despite 11 years of work on this. And after 11 years of work, the finance committee came back and said, guys, this is not flying. It poses significant additional risk to the public and private healthcare system without any evidence of advantage to the public sector. And it does not expressly, address the actual problems that exist within the provincial health systems, where you have to improve the delivery of health care. This bill does not address that. And they ignore any viable and easier implementable reforms that have been proposed in the past, that have been identified, which showed on a roadmap that can be done. So I'm concluding by saying, get the balance right between equity and efficiency, and where you put the fulcrum is important. You can only improve efficiency by decreasing cost and increasing quality. And we have to provide equitable and universal care at the highest possible quality at the least possible cost. We can't do it by selling pipe dreams. We can't do it by ideological reform. We can't do it by ideology. We have to have a practical plan. Because I'm representing ECIPA, and when I went and presented this to the portfolio committee, they asked a question of me to say, well, what are we supposed to do, Dr. Pillay? Because you are raising all these issues, what are we supposed to do? I said, portfolio committee, if you are the speaker and you are a member of the portfolio committee, before you pass any policy, new policy and bills in the NCOP and the provincial legislature, please ask your respective departments to give you an account on the previous mandates. Here's a list of the mandates. Tell us what you did. In the legislature, you should ask for a clear, coherent, sequence implementation plan with timeframes. Don't go and rubber stamp what the department presents to you. The Concord ruling in the Jacob Zuma case is clear. You, as the legislature, you represent the people. You are supposed to come up with a policy, give that mandate to government and cabinet, then monitor them to implement it. You cannot have the policy coming from government and you rubber stamp it. Then who is the monitor? A true legislature, true people's legislature will themselves formulate policy after consulting with the people, and then mandate and monitor the government. And this is what was done in the Taylor Commission. There was a whole committee set up. A whole lot of people went out. They identified the problem. They listed the problem statement. They came back with a diagnostic report. They came back then with a proposed solution report that was canvassed. After canvassing of the solution report, what is feasible, what is not feasible, what can we do within what time frames, and then they gave this mandate. That is a consultation process. That's how legislature is supposed to work. Now you want to have a cabinet that does not want to be accountable like that, and will be told to do these things in a particular manner. They come and give you some nonsensical thing for you to implement and say, rubber stamp this, and what the hell are you going to monitor? What are you going to hold them accountable for? Because you've not implemented any of the previous mandates. So why do you want a new policy? When the future of healthcare is at stake, one has to be cautious with incremental implementation in a phased and monitored manner, and we should avoid untested ideological plans. So, and that's why I want to conclude. Thank you. Thanks, Jeff. Take it from there. I don't know if you've got questions or anything.
There are a few questions and comments. But firstly, thanks very much for your sharing your considerable insights. Let me switch on my, oh, that's great. Sharing your considerable insights in such a frank and bold manner, to put it straight, fearless. So in essence, you stated it, citizens have lost trust in government due to the failure of all the SOEs. And then thanks for your critique of NHI, like no other that I've seen or listened to, with all the detail and the processes over the years. So we really appreciate this. And as a member of ECIPA, you being a member of ECIPA, we are proud to actually collaborate with you to set up this webinar. It sounds like a public debate between yourself and Dr. Nicholas Crisp is required, because your points, many of them contradict what he states, and it seems like you guys have to come together. If you agree, I think it's something that we need to put together. Yes, you made the point about electioneering as well, and I think many of our colleagues share many of the concerns that we might not be able to express it as eloquently and insightfully as you. So with those points, I'd like to just go to the questions, if I can pull them out here. The first one was, thank you for an amazingly detailed, insightful presentation. This needs to be presented to Parliament. What's your response?
Jeff, just list the questions, then I'll try to sort it out.
Maybe you answer them one by one.
Okay, the response to this, that's what ECIPA is trying to do now. That's why we're canvassing this platform. We're hoping that after we do this year, I'm going to have another presentation in other places. I'm hoping that Alex van der Heever is doing some things on the other side. I believe there's a parallel session running now with JJ Tabane, Angobotsa Tabane in Durban. And we're hoping after this, we will be able to collate something that is comprehensive, not to go to collate a document, to request that the portfolio committee, both national and NCOP, convene to listen to concerned people about what our concerns are before we go any further. And that's what we are trying to do. I mean, the whole thing started off, Jeff, I retired, I gave up on this thing, where I decided to go to a portfolio committee meeting. Now, our provincial portfolio committee meeting is going to set up a date for us to present to them. But to present to our provincial portfolio, they have no sway in the national. So we have to get a method, either through a vote or something, to get the national portfolio committee of the NCOP to listen to some presentations before they start voting on this. And I'm hoping that you set up, young guys like you who got more energy than me, will set up something where you can set a petition or something for them to do this. Thanks.
Thank you for that response, Siva. The next one is, could public hospitals not contract private organizations to do their medical billing for them? Why not consider setting up such an organization that will clearly, financially revitalize public hospitals?
Yeah, this has already been done. That's why I said, we have 9 provinces. Surprisingly, the one province that is not ANC is doing it. In the Western Cape, they're already doing that and they're generating income. They've got differentiated amenities, they're generating income. The UPFS is up to date. The tertiary services is there to an extent that they went and outsourced. They went to say, we will provide oncology services and others, and they are DSP providers for many things. So the ability to do this exists. By the way, Treasury in its financial systems gave out a billing system to all the provinces to implement, but they never maintained it and they never maintained the fee structure, because it was supposed to be individual fees to be charged according to UPFS tariff. We had a chance to say whether it's going to be a global fee or individual fee for the hospital, including or excluding the RWAPs. We never maintained a system, but that there is a small thing to do. We did it in UDIPA. When the people here did not know how to bill, we said, fine, we'll do the billing for you. We will do the collection even for you, and we will give you the money. So we did that.
You say the systems are there, but implementation is lacking.
Political will and the knowledge to understand, and public servants want to do as less as possible. because they don't see the benefit of doing this. Because what's happening, unless you have revenue retention, give you the example of Utneg Hospital. We were spending about 10, 12 million rands, but we were earning 20 million rands. So that's an 8 million rand profit. But the whole 20 million rand goes to provincial treasury. We don't even get our 8 million rand back. They said, madness, we're not going to do this. We're actually losing 8 million.
Thanks, Siva. And the next point was, Siva, you clearly have an amazing and above average understanding of this. Please consider partnering with, say, Discovery to assist the state in all these avenues.
We don't mind partnering with many people. There is a progressive health forum. There is a lot of people who've got a lot of knowledge. And this is what people said. If people are called together and they are listened to, but if you are just summarily dismissed and you're considered reactive and people then start labeling you, and they use a process of where racism is brought into it, where it says, we don't want to bring healthcare to the black population. We want to keep it to the privileged. Which statement is illogical? Because that's not what the NHI is about. The NHI is to bring healthcare to all the people. But if you listen to the proponents of this bill, in what they say in their public statements, this is what they say. So you're asking, are people listening? And do these proponents of this bill, do they want to do this? Or is it coming to what Alex van der Heever said? You've already framed an endpoint, and now you just want to fit in the issues to fit in your particular framework of what you put in your endpoint. And so if you get a clear listening process, that's there. A typical example of this, Jeff, is that we as healthcare professionals also, how much interest are we paying in this? If you go ask any average doctor, nurse, or anything, what the hell do you know what's happening? And the knowledge base is terrible. I went up to COSATU once and I presented this thing here, and I just went over people's heads. And then the people said, Hugh, Siva Pillay, this is going to create problems for us. Why did we agree to it? And I said, but you guys, you agreed to it. Can you imagine your national fund that is going to buy healthcare for the whole country is equivalent to an Ngonyama Trust or Boxing South Africa fund? This is a joke.
I think we need to have a debate on that. I think Dr. Crisp would have a response. So the next is the statement.
His response, I know. He says, no, there are a lot of other organizations there, the Competitions Commission, the Medical Schemes Council. And I said, those things do not have public funds in them. They are not a national institute where you're going to provide what is called an essential service like health or education or housing. It's a different mandate from boxing or karate or brand South Africa. Are you mad? If you can't see that difference now, then there's something wrong.
So we've got quite a number of questions to go through. The next one is a statement. The UDIPA capitation system was in miniature NHI. Lessons have been learned. NHI is desirable, but the road is long.
Well, you know, what I did was I took the Dable plan, and I took the Dable plan costing, and I took everything that the Dable plan said, and I put it into UDIPA. The doctors who worked in UDIPA will tell you that they earn 30% more than what they earn now with the medical aids. The provincial hospitals will tell you that they raised money and they got more money than they bargained for. And the doctors also got a share from that money. So it was a symbiotic relationship. I just implemented the Dable plan, which all doctors rejected at that time.
So I'm going to quickly read through these comments. You can make a note of this one. Where do we go from here? You can answer it just now. The next comment is, really appreciate your honest, unbiased analysis of NHI. Next one is, most people who talk and debate policy do not have the boots on the ground. Next one is, do you think us GPs in our twilight years with so much experience have any role? Make a note of that. The next one is, give this man a bells. But I don't think he drinks alcohol. The next question is, will anything happen before the election? Siva, make a note of this. Will anything happen before the election? Then a comment, excellent dissection of things to come, fantastic insight. This is the kind of leadership we as doctors need. Definitely requires a rerun to a broader audience. And the last one is, hi everyone, we have not considered the brain drain, which is already evident in my microcosm.
Okay,
so
Jeff, let me go to this. Where do we go from there? Yeah, I think I answered the thing. I think we need to organize, we need to get a petition going. We need to go and try to say the bill now has gone past National Parliament, so you can't go and lobby them. It's out there. The next place you got to go and lobby is NCOP. Hopefully the people from National Parliament will be in NCOP again, and you can go and look at it. The next thing that you can do is, which we are doing and which I am doing also, I am saying, don't misunderstand me. I am not against NHI. I actually want NHI. But I'm not wanting this bill, which is just going to set up a fund for some people to eat from. So there are people who are preparing constitutional challenges, and we are doing research about that. There are people who are preparing to say where the bill is flawed, that will be challenged in court, and there are some people doing some work on that. What we need to do is to galvanize all people together to get a coordinated response. ECIPA has got to work where it has to, because I can't represent ECIPA in this, and I'm represented ECIPA once. They need to go and write that letter to request the portfolio committee and request the NCOP and to get a petition. So the thing about people with boots on the ground not knowing this, we have to go and inform people what we are doing. And what is the role of a GP? As I said, nothing. This bill is proposing no changes in the next 6 years. But what is the role of the GP? You know, the GP and the people, all of healthcare's resources must be used for all of the people. So if you do the thing like we promised before, it should be both private and public included and providing the services together. And that's one of the things that we're providing in the legal challenge. You cannot provide false information to people at a public hearing where you say, no, we want a single purchaser, single funder system because, you know, 80% of the service providers, doctors, and specialists are in the private sector and we are staffed in the public sector. Whereas their own report showed that 71% of the specialists are in the public sector, but they are not working in the public sector. You gave them RWAPs to work in the private. So you can't go to and mislead people and say that is representation. So we will be challenging the issue about how representations were made and were those representations meaningful, substantial, honest, truthful, and based on factual data given to people. Don't just come and say, you know, in Kosa, I don't know how many people know Kosa. You go to a Sangoma and you say Vuma and you say Kamaku. There's no debate. You can't do that. Will this thing be before the elections? No. But there's an insidious thing about this. It slipped in an NHI bill, or an NHI fund, under the guise of an NHI bill to set up an NHI fund. That may be implemented. And that's the danger that we face. The issue about brain drain, economic growth, and all the other things, there is a whole issue about the economic impact of implementing. I got slides on this, but I thought it will take it too long. The economic impact of implementing an untested policy and an unstructured policy in an existing system and causing a collapse of that system. And that's why I'm saying we're going to have to use Section 39 of the Constitution to say, if you're withholding rights, are you really doing it in a proper manner? So the whole system in the country and the way it is contributing to economic collapse and brain drain and immigration and all of that. But that's another debate. I'll stop there.
There's another point here. As much as you may consider it a moral compromise, please consider having this recording made available to the shadow ministers of the Get Things Done political parties like the DA. Your response?
Let me answer that question. Whoever thinks that the Get Things Done political party like the DA, I want to say to them right now, the mess that we are in what people do not understand is because of the DA and Tony Leon specifically. Mandela, during the negotiation period of the interim constitution, wanted one national government and strong districts and no 9 provinces. It was the DA that brought in 9 provinces. And why they brought in those 9 provinces was they said the ANC will end up in a feeding frenzy to elect 9 premiers, 90 MECs. They will get so comfortable with this, they will get away from the people that they represent at the moment. And that was a political decision that was taken at the expense of the country. The second thing that I want to say, the Get People's Done. It is the job of these Get People Done people who are opposition. The job of the opposition is to go in parliament and ask questions and say, we gave you mandate, guys. What did you do with this mandate? To ask questions in parliament, not to get a fat salary and sit at home and then have debates on TV. You should be calling your minister, you should be calling your cabinet and say, listen, we gave you this Taylor Commission report. Let's come and give us an account of what did you do with the funds that you appropriated for these 10 pilots. Come and give us an account of what you did with the money that you appropriated for the revitalization of public hospitals. They don't want to do it. And that's what I'm asking. What is your job as opposition? You cannot expect the ANC to question its own minister when we have a flawed system. So I don't believe they will get it done. And by the way, I have spoken to people, and at one point in time, I forget his name now, who was the shadow minister for health. I tried working with him. I worked quite well in the province with John Copido. And I actually believe that you should listen to the opposition because they have valid criticisms. Your own friends won't criticize you. So you listen to the criticism. So when I was HOD, I went and I had a regular meeting once a month. You know what the joke was about that? I scheduled the meeting to go and listen to their concerns. Half the time they didn't pitch. So political parties, whichever they are, and that's why you have to have a people's parliament now and a people's process. And that's why I'm campaigning for change in this electoral system where we don't vote for a political party, but we vote for MPs to represent a constituency.
Just some comments. Better management of the same funds will lead to better outcomes. Thank you, Dr. Pillay, for a wonderful presentation. And then, is it possible for this presentation to be emailed to participants? And the last, currently, is very impressive talk, Siva. I guess some countries are already running NHI models. And obviously, there are lessons to be learned from those countries. Would like to hear your comments in this regard in the next talk.
I can give a comment on that right now. You know, it's really a joke. After the Taylor Commission was passed, we called in an imminent group. So we called WHO, and WHO said, no, we'll send you a team. We'll send you, Sir Peter Ain, we'll send you Curtin, we'll send you other people, and we'll massage your policy and we'll make it perfect. And we drew up that, which came the Taylor Commission. Do you know what the joke was? Thailand took this thing, and in 8 years they implemented, and they've got 90% universal coverage right now. They just took our South African policy as it is. The second thing is that the government in its presentations keeps saying to us, we want a single purchaser, single fund unit, and that's how it is everywhere. I'm asking where? The NHS even has private sector in it. All other countries have multiple systems into it and controlled and managed together. So how do you say this? And because we have a lack of knowledge of what's happening in other countries, we are just being fooled by what we are being told.
Well, there's another point
The question that you asked about what you're going to do with this, you are the convener. I represent you here, Jeff. You are the chairman, so you have to say what you're going to do with the presentation and what is going to happen. That's for you.
All right.
This is an ECIPA presentation. It's not Siva Pillay's presentation.
Okay, but you put it together. And are you happy to have it shared?
Yeah, no problem.
Okay. The problem, the next point is, the problem is that it is unlikely that any of these parties have anywhere near the insight and historical perspective of the subject that you have.
I don't want to say
for once you're speechless.
Yeah, and there's another comment that the NHS is nearly collapsing in the UK. I am saying that there are a lot of people, but they got punch drunk. There are a lot of people who got a lot of knowledge. If you look at Tim Wilson, Alex van der Eva, Diane McIntyre, Buyo Tom, there are a lot of people who got knowledge about these things. Surprisingly, I'm trying to figure the guy's name out who was in the DA also. He was really a good guy. And he had knowledge about this at that time, and he raised various questions in Parliament. I used to write the questions when I was a member of Parliament and give it to him. I said, I can't ask this question. Can you ask the questions? And he asked the questions. It was very good. And so it's there. The NHS is nearly collapsing in the UK for a different reason. And that, I think the dynamics of that is different from South Africa. And that's coming to over-servicing, over-promising, and an abuse of the system, and a funding model that is little bit now controlled by government too much, and there's too much government meddling in it. And the whole story changed when the previous Conservative government under Margaret Thatcher in a Thatcherism changed the structure, and that's a problem.
Thank you. I don't see any more comments or questions. It is now 8:32, so we've been at it for 1.5 hours almost. We had a maximum of 103 attendees, including ourselves, and we're sitting with 93 that has sat through and listening to the entire discussion. So Siva, in essence, you're saying jack up the current public healthcare system and allow it to coexist and compete with the current private sector and move forward like that, and then synergize. Would that be, in essence, what you're saying?
I'm saying that, and I'm saying that if they do that properly, they will put the private sector to shame, like we did with the ECIPA hospital. Yeah, and you can really compete in a proper manner. Now, because the private hospitals and the private sector have no competition, they're just doing what they want. So they are also inefficient.
The colleagues present here perhaps type very quickly in the question and answers section what they think should be the way forward. And we can make a note of that. What should be the next step? I think we've kind of put our feet in it, or foot in it, Siva.
Yeah, no. I remember, Jeff. I remember I represent you, so you must answer all those questions. Is there anything else, or we call it a day?
I think we're done. I don't see anything further. Oh, wait, there's one more that came through. Yeah. There's a comment here, another meeting, a broader audience, bigger role players included. Okay.
That's for you, Jeff.
Yeah. Okay. Allow me then to once again thank you, Siva, for a most informative, insightful, bold, fearless presentation. And to everybody present here, thank you for attending on a Friday evening to Discovery Health, Morris Goodman, Siobhan, and Anand Naika for assisting me in setting this up, and then for Andres from the technical side at Discovery for sacrificing his Friday evening to be with us to make sure that everything is functioning correctly. With that, I'd say good night, take care, and stay safe. Thank you, Siva.
Yeah, thank from my side to Discovery and to Andres. Also, thank you very much. And to everybody who participated today. I think Jeff needs to come to a process where we can collect information and then see how we take this forward. Thank you.
Okay, I just want to I'm trying to get all these questions before we lose them. I'm sure Andres will be able to export them for us and give all these questions to us.
That's true, Doctor.
Okay. Right. Andres, once again, thanks a million. And I think we can close the webinar now, and you'll make a recording of this available. Siva, are you happy for this recording to be uploaded to YouTube?
Yeah, no problem. Just put it
Okay.
on the ECIPA banner.
Okay, we'll do that. Thank you. Thank you, Andres. I'll wait for the recording.
Pleasure. Bye-bye.
Thank you. Bye. Bye, everybody.